Welcome to today's webinar from Scottish Drugs Forum. My name is Fiona Doig. I work for NHS Borders and I am the Head of Health Improvement and the Strategic Lead for Borders Alcohol and Drug Partnership. So my role involves leading the health improvement team to reduce health inequalities and improve health and wellbeing over the borders, and also to lead the work of our local ADP. Today's webinar will be talking about alcohol and drugs issues in remote and rural areas in Scotland, and in particular the challenges that COVID-19 has brought us. Delivering services in remote and rural Scotland brings unique and persistent challenges despite all the progress we've made in recent years. COVID-19 has made it even more difficult to deliver services to the most vulnerable people in our area. However, despite these challenges, some of the responses we've brought to the pandemic have been innovative and positive and might change the direction of provision in the future. Today we'll hear from some local policy makers and providers about the challenges they've faced and the opportunities they've seen through this pandemic. And they'll talk about what they want to keep and what they've learned for the future. First up, we'll have Jacky Davies, who's the coordinator at Dumfries and Galloway Alcohol and Drug Partnership. And then we'll have Rhona McArthur, who's a team lead at the Substance Misuse and Recovery Service in Shetland. Our final speaker is Jacky McDermott from SHAP, Scottish Health Action on Alcohol Problems. Following the presentation, there'll be an opportunity to ask questions. During the webinar today, if you'd like to submit a question, please type it into the question tabs. You'll see this in the control panel on the right-hand side of your screen. Following the presentations, we'll be joined by Austin Smith. He's a Policy and Practice Officer at SDF, and he'll help summarise the questions and present them back to the panel. I do hope you'll enjoy the webinar today, and I'd like to introduce our first speaker, Jacky Davies. Welcome, Jacky.
Hiya. Right, hi everybody. Right, so this afternoon I want to provide you with an overview on Dumfries and Galloway's injecting equipment provision, and to look at what happened when lockdown began and what we did to make sure that people could actually access clean equipment. So first I thought we'll have a wee geography lesson on Dumfries and Galloway and where we have IEP services. So D&G, as we call it, is a large area made up of a mix of rural and urban towns and villages. It's got a population of 149,000 and the population density is 60 people per square mile. That's compared with the Scottish average of 168. So we're pretty well spread out, and that shouldn't have any problem having social distancing in place, as we've got the room for it, and that's despite the current cluster of coronavirus cases in Dumfries. So anyway, D&G is made up of 4 districts. So starting in the east, we've got Annandale and Estill, and we've got 3 pharmacies delivering IEP in that area. So that's 1 in Gretna, 1 in Lockerbie and 1 in Annan. So moving west, we've got Nithsdale, and it includes our biggest town of Dumfries. So here we've got 2 pharmacies, both in Dumfries, and we also have We Are With You, who provide a static site in the town. So carrying on our journey out west, we have the Stewartry, and it's got 2 pharmacies, 1 in CD and 1 in Kirkcudbright. And then finally, heading out to the Wild West, we've got Wigtonshire, which includes Newton Stewart and Stranraer as the main towns. Now, there are 4 pharmacies that serve Wigtonshire, and that's in Newton Stewart, Stranraer, Whithorn and Wigton. And We Are With You also provide a static site in Stranraer as well. So there's no mobile outreach service in Wigtonshire, and that's the reason for there being more pharmacy provision there than anywhere else in the region. Mobile outreach, though, is provided in all the other 3 districts and is able to reach the more other outlying smaller towns in Dumfries and Galloway. So you can see the likes of Moffat and Thornhill are up north, and Langham is out further east. The outreach service is able to provide the necessary equipment to clients in these areas as well, so that's helpful. Go to the next slide, please. So when lockdown was thrust upon us, many of the pharmacies suspended their IEP provision. Now that was due to them prioritising their services and also reducing the hours that they provided those services. So those who would normally access pharmacies for injection equipment now had to look at other outlets for it. And there was concern that maybe some people would start to reuse their equipment or share with others, you know, so it's something needed to be put in place pretty quickly. So that was the issue with the pharmacies. Then meanwhile, the NHS Specialist Service, which has provided a mobile outreach service for 29 years now, their outreach worker was required to shield due to medical reasons. So we had a bit of a double whammy for the IEP service. However, the other IEP service provider, We Are With You, although they had reduced their opening hours of their offices, IEP could still be ordered over the phone during normal working hours and collected when the building was open, or if they needed to be, they would actually deliver it for people. So I want to kind of give you a bit of a context as well about our numbers of needles that we distribute in D&G. So we've got the 11 pharmacies, and We Are With You together give out around about 100,000 needles a year. The outreach worker himself gives out around 100,000 needles a year. So half the needles in Dumfries and Galloway are provided by the outreach worker. Some outreach clients provide secondary distribution, whilst others would use both the pharmacies and the outreach worker as well. But there are a number of clients who received their equipment only from the outreach worker, and that was due to the knowledge that this was quite a discreet service that was provided and that trust has been built up over a number of years. So the impact of losing that outreach worker was huge. So as a result of this, we needed to ensure that we could provide IEP services despite the sudden impact of all these changes. So can I have a next slide, please? So here's what we did. The Specialist Drug and Alcohol Service quickly identified 2 members of staff to take over the role of the outreach worker. And because the outreach worker himself was just shielding as opposed to being off sick, these staff were able to use him as a middleman. So he would collect the orders from his regular clients over the phone just as normal, and then these would be passed on to the staff so they could make up the packs and deliver them to the clients. So kind of after a few weeks, the staff themselves had managed to kind of gain that trust of those who were delivering the service to, and some of the service users themselves started contacting those staff members directly. So this was a positive result, showing that the clients actually trusted these new staff that were out and about. The support of the outreach worker as well had definitely helped to reduce any resistance to the change in the staff as well. So there's been good feedback from some of the people who continued to use the service. An IEP was also supplied to a number of people who had never accessed the service before. So these are going to be people that were maybe accessing only the pharmacy before, but they couldn't actually get access to the pharmacy, so we're now actually accessing the outreach service. The third sector service as well also played a pivotal role in ensuring people get access to clean equipment. So We Are With You quickly put in place an online click and collect service, whilst also providing a delivery service to people who were unable to collect their equipment. And I think one of the main things for us as well was that the communication was vital with everybody. I mean, social media was used to get the message out around all aspects of service delivery. The outreach workers' communication with his clients ensured that they still received a service. And the communication between the outreach worker and the 2 staff who are now delivering the service was also crucial. And we in the ADP, we were in regular contact with the services just to ensure that the injection equipment was easily available and to address any issues if any arose. And then as lockdown kind of progressed, the pharmacies were able to restart their IEP service, providing another option for clients again. Can I get the next slide, please? So finally, I just wanted to show you the impact that lockdown has had on our number of needles given out. So the chart shows that the 6 months pre-lockdown, which were averaging around 16,000 needles a month, and then at the end of March when lockdown began and at the beginning of April, you can see that dramatic drop in the needle distribution. I mean, it began to rise again to the point in June where we were back at normal levels. But since then, the numbers have been on the decline again, and I'm not entirely sure what the reason for that is. We've had a look at the referrals into services, and this doesn't show any significant increase in new drug clients, although there's been a few extra, but not enough to kind of think that it would make such an impact on our IEP equipment. We also looked at the IEP providers to see if the numbers had dropped right across the board, but interestingly, the pharmacies are back to their normal levels of distribution, whilst both the Specialist Drug and Alcohol Outreach Service and We Are With You have decreased in July and August. So we maybe need to take a wee bit more time just to see what's happening in these areas, and just to see that this isn't going to be a trend heading back down again. But I think overall, we learned that the services could adapt to change very quickly, and that the service users appeared to adapt to that change in the way they access their IEP equipment. Feedback from the service users using the mobile outreach service was positive. So for us as an ADP, injecting equipment provision is an area that we have decided that we've been looking at recently and that we want to look to develop over the coming years. And we'll take this learning from this to engage with the IEP service users to help shape our future of our service delivery. And just finally, I think I would just like to kind of take the opportunity just to thank the managers and staff of all our IEP services for their professionalism and their quick response to this situation, which ensured that the clients actually continued to receive clean injecting equipment. So thanks for listening.
Thanks very much, Jacky, for an interesting presentation and some thoughtful insights into what that means going forward for us. I'd like to now introduce Rhona McArthur, who is the coordinator for, who's the team lead at the Substance Misuse and Recovery Service in Shetland. If Rhona is able to join us. Lovely, thank you.
Oh, thanks very much, Fiona. I want to thank the SDF for asking us to be involved in this today. I'm Rhona, I'm the team lead at the Substance Misuse Recovery Service in Shetland. And I'm going to tell you a little bit about how we as a service responded to COVID and where we're at now. I don't have a nice map to show you where we are, I'm afraid, but we're an island community of around and about 22,000 people. Were located, if you don't know, somewhere in the middle of the North Sea, up in the north east corner. And we serve a remote and rural population. The service works with the whole of Shetland, and Shetland is comprised of a mainland island and some inhabited outer islands. Our service currently has around and about 290 people, and that will be a mix of drug and alcohol service users. Can I have my next slide, please? So the impact of COVID-19 on our service, it came pretty quickly. It certainly added a new dimension that we had to look at and overcome. What happened in Shetland was we had a sudden surge of cases, kind of late March. And I guess as an island, what that meant for us was we locked down pretty early. We locked down a week before everybody in the Scottish mainland. And fairly quickly soon after that, the travel lockdown. So for an island community that relies on transport links, and for a small community that's quite social and relies on community engagement, it had a fairly big impact pretty quickly. I think as a staff team, we had to really quickly adapt how we engaged with other staff and services, as well as our patients. And I guess from my point of view, kind of always keeping in mind patient, staff and community safety, there was a lot of elements to look at. Again, along with everybody else, there was a raft of new guidance and new ways of working to work through. And I think as a team, we did that really well. We communicated really well with each other, and I would say we were well supported by the ADP and by the department we work in. Obviously, along with everybody else, was strong focus on infection control, and we were lucky enough to be able to employ 2 locum staff who, along with our existing team, we worked really hard to maintain the service. Next slide, please. So for people who use drugs, what patient group certainly really struggled with the lockdown restrictions. I think it's quite a difficult thing. I mean, our most chaotic drug users, I would say, struggled the most. not being able to mix with each other and having to stay in their own houses. We had a number of people who were shielding in the higher risk category, and again, they really struggled to understand the risk that they were in and the risk that that potentially posed to other people. I would say that the availability and types of drugs that we had here changed pre-COVID. We were certainly seeing a spike in different kinds of drugs being available on the island. We're quite often targeted by organised criminal networks from the mainland, and that our supply chain of drugs routinely would depend on that. Because our transport links were effectively shut down, you couldn't leave the island without a piece of paper that said you could, and likewise you had to have a reason for travelling into the island. So that limited how drugs were taken in, but it certainly didn't stop the supply of drugs. I think what we saw predominantly was an increase in tablets, benzo type tablets, and that led to different issues for communities and for our patients as well. We limited attendance for face-to-face appointments, and that was about infection control and safety as well. However, we continued to see people. We felt it was important to continue to offer a service, especially to our most vulnerable and chaotic patients. So we did that, and we stayed within the guidance, and we used PPE, and I guess some of the issues with that, and kind of some of our continuing issues with that, was that our patient group would regularly just turn up, and that might be because of drug use or because of chaos, and they just needed support. In terms of prescribing, we reviewed all the prescriptions and liaison with our specialist pharmacist and clinical team. And the patients we changed were supervisions and dispenses, but we didn't do that across the board. We have 4 dispensing pharmacies, and they all kind of wanted us to work differently. Our biggest dispensing pharmacy is also the provider of our injecting equipment provision, and they probably kept the bulk of the supervision for our patients. And for those that it was safe enough for take-home medication, that's what we did. For people out in the remote islands, we got the medication delivered to them to reduce their travel in. We increased ward delivery of opiate replacement therapy, we increased delivery of injecting equipment provision, and we also increased ward delivery in Naloxone to people as well. So we really tried to keep people as safe as possible, and keep the staff as safe as possible as well. I think it probably at its height we were probably delivering to between 20 and 30 people a week, and we're outreach needle exchange, definitely the work there definitely increased as well. Through to all, we stayed open to referrals for drug misuse. We did some more arrest referrals where we did cell visits to some of our patients who had been arrested, and we continued with acute liaison work with the hospital. Next slide, please. In terms of alcohol services, again, the patients struggle with lockdown restrictions and the guidance, and that sometimes meant that they got into trouble. Unfortunately, with alcohol, its availability never changed up here, and for lots of people, it became easier to source due to home deliveries by the bigger supermarket and local shops as well. Again, we limited face-to-face, but where people needed support or were really struggling with their substance use, we saw people, we utilised technology for remote appointments, and we did community engagements as well with recovery workers, met people outside for walks, and were able to socially distance. We adopted our own guidance locally in conjunction with our dual diagnosis GP, and we were able to continue to offer community alcohol detoxes. We got new equipment and increased our PPE. So that was really brilliant. And we made a case for the continuation of acute inpatient detoxes alongside the consultant psychiatrist. we worked really hard to develop a new pathway with the medical team, and it was closed initially, but pretty soon into COVID lockdown, we were able to admit patients for planned alcohol detoxes in the hospital as well. Next slide. So new ways of working, how are we working now? And I think the main goal is always to ensure the safety and support for staff, patients in the community. We continue to offer face-to-face appointments. That has, as lockdown restrictions eased, we saw more people face-to-face. Our patient group are really used now to having telephone appointments or remote appointments unattended anywhere, and things like that. I think as a staff team, I've been really impressed by how the staff team have embraced the change and worked really hard to still be able to deliver a service and deliver support. We've come up with a lot of different ways to be able to still engage with people. We've utilised IT that was available, and we're now, as a whole staff team, able to work from home. And that's been really useful for us. In the beginning of lockdown, because of the remote working, we started a morning check-in and check-out to support staff, but also to maximise communication around our more complex patients. And I think that that's been really useful for us all. I think we've been able to better look after some of our more complex people. But also I think we're communicating better as a team, so that's been really good. And of course, new ways of working, I think, for us all, is going to include more infection control and more awareness of where we are and what we're doing and our PPE. So I think although COVID certainly presented a huge challenge and a huge lot of change, I'm really impressed with, as a team, how we've been able to adapt to that, and I think my patients have really appreciated that we're still here and we're still seeing them and we're still available. So yeah, I think we've done good so far, and it's just about keeping it up now. So I think that's right.
Thanks very much, Rhona, for a very clear and helpful presentation, taking us through your COVID experience. It's probably timely now to remind you, if you would like to submit any questions for the panel for later in the session, then please put them in the question tab. And I'm pleased to say that Rhona's colleague Wendy McConnachie, who's the coordinator for the ADP in Shetland, will be joining us for that Q&A later on. Having heard from our two local providers and planners, we are now going to move on to our third speaker for the session, and that's Jacky McDermott. Jacky is a research officer at SHAP, and so I'd like to ask Jacky to come to the screen.
Hi there, thanks very much. Perfect. Okay, well, thank you very much for those really interesting presentations, and also to SDF for the opportunity to speak with you all today. Really appreciate it. And my presentation is about a project that SHAP has been working on for the last 18 months. And it is about understanding cultural, socioeconomic context between alcohol and rural areas, learning more about support and barriers to accessing support. And our aim with this study is to provide recommendations for research, policy and practice to the Scottish Government, who are our funders. And just to provide a little bit of background info about SHAP, we're Scottish Health Action on Alcohol Problems, and we represent the medical colleges in their efforts to reduce harm from alcohol and to support recovery. Can I get the next slide, please? Thank you. Okay, so in terms of who we spoke to and how we undertook this project, so we started off with 5 consultations. Those took place in 2019, and I've actually spoken. I want to just say thanks to Fiona, Jacky, and Wendy, who are all here. It's nice to see you all again, and I know I've spoken with all of you throughout the course of this project, and yourselves and other ADP coordinators were really, really helpful in helping us get participants for our interviews and also for our consultation events. And I'd also like to thank the Scottish Recovery Consortium, who also were very helpful. So at these events and also with our interviews, we aimed to include kind of as wide a group as possible in order to explore these issues of alcohol use and alcohol harms and some of the challenges and opportunities for providing support in these areas. So we had people with lived experience, people in social work, services, NHS, and our links also with 12-step fellowship members as well. Those were all good. I'll also just add, it may seem odd that we had all of these consultations in very urban centres, but we had teleconferencing and video conferencing options. And after speaking to people, we decided that public transportation hubs were kind of the easiest option. So throughout those consultations and throughout the interviews, we managed to get participants from all of these communities that you see here with significant remote and rural populations, which was great. And that allowed us to gather our qualitative interview participants, which you see listed here. That included people in recovery, young people, people with family members with alcohol problems, NHS staff, and also some third sector service providers as well. Can I get the next slide, please? Thank you. So this project is going to be, the final report on our findings will be launched on September 23rd, which is coming up. So that's when the final report and our recommendations will be up. And I'll give a final plug at the end of my presentation for that event if you're interested in learning more. But I'd like to share some of our initial findings from the project. Obviously, when we started off, we had no idea that COVID was coming. So the consultations were pre-COVID, but actually most of the qualitative interviews took place over the last 6 months. So the majority of those took place within the context of the pandemic. So some of the report, a great deal of the report is informed by that, and the conclusions and recommendations that we came to reflect that as well. So I think from the evidence from people that we spoke to, both service providers and people in recovery themselves, I think shows that there are some opportunities and obviously some great challenges also during the pandemic, but also in terms of how we move forward with new ways of working. I've listed some quotes from our participants here. These are from 3 different participants with whom I spoke during the project. And the first 2, I think, kind of highlight some of the opportunities that we have. So I'll read them out. So the first is, a lot of folk are actually happier having access to technology and accessing services this way. And we've had some feedback from the community mental health team that their clients feel comfortable doing this. So perhaps modern technology will offer us a means of overcoming these problems. And the second is, one of the things we've found that's been an advantage to people through the COVID-19 crisis has been that people can engage on Zoom meetings, not leave the house to do it, not have to tell anyone where they're going. You don't have to catch a bus that's only once every 3 hours, or spend all day getting somewhere for an hour-and-a-half meeting and then travel all the way back again. So I think a lot of the kind of challenges and barriers to access are sort of highlighted in those quotes, because obviously, as you'll all know, in rural areas, public transportation can be a real challenge. The cost or the frequency, as is mentioned in that second quote, is a real issue. So if you're able to get a service such as counseling online, this can be really useful, very cost effective, more efficient, easier to access. And also, I think another thing that's highlighted here is potentially one of the ways in which we can sort of combat stigma. I know it says in the second one, particularly people saying that they don't have to leave the house in order to attend a meeting or to attend a counseling session, because obviously stigma is something that's very relevant no matter where you are in the world, or no matter where you are in Scotland for that matter. But I think in speaking to people and gathering evidence from this project, it became clear that I think there's unique challenges faced with people living in rural centres just because of the difficulty in maintaining anonymity, and people saying things like everyone knows where the AA meeting is and what time it is and which building it's in, and I feel like I can't participate because it may affect my family or it may affect my work. and that kind of thing. So online alternatives may actually go some distance in combating some of those issues. I think another thing that I'll point out as well, it's not highlighted in these quotes, but it was another thing that I think is kind of a silver lining from this, is that I think for service providers and healthcare professionals, this COVID-19 has proved to us that we can work really effectively in terms of education and training and networking opportunities. And that, for example, this webinar would be a great example. I'm sure there's people from all across the country who have joined us who probably wouldn't have been able to, take a day off work to travel down to Glasgow or Edinburgh or anywhere else to participate in something like this. So I think it's far more equitable, it's friendlier to our planet, it's more efficient, cost effective, etc. And I think if we can help people in that way, I think that's also a really good idea in terms of how we move forward, in terms of taking the positives and the learning opportunities for whether it's getting accreditation online for counseling or other training, all of those things. So I think it's good to keep that in mind as we move forward. Now, in terms of challenges, this last quote was from a participant who's very active and is a leader in the recovery community that they're a part of. I'll just read out the quote. I think ultimately we want to get people up and out of their houses and learning new skills and getting connected and socializing. We think our next thing might be to do some beautifying of the area. My old scheme, I would like that to be top of the list. The place is an idyll, it's absolutely beautiful. So I think in speaking to this participant, that they were sharing that so much of the psychosocial support for people who are in recovery comes from that human connection, the friendship, and the kind of the joy in recovery. This is all really from in-person activities much of the time, like as we've all become painfully aware over the last few months. There's obviously nothing that can really replace an in-person activity or meeting. And I think, depending on what stages of lockdown were in place, people were very innovative. They set up online meetings, WhatsApp groups to check in on one another, phone calls and all that kind of thing. And then they were able to, as was previously mentioned, there were other things that people were able to do, such as going out for walks, or recovery rambles was the term that I heard, which I absolutely love. So recovery rambles, and as is mentioned in this quote, some gardening and kind of outdoor things, which I think are all really nice options in terms of making these kind of peer support opportunities more accessible, maybe for people who aren't sure, just getting started. So I think obviously during the pandemic, all of these things have been incredibly challenging, and they continue to be obviously tough to access, even at the best of times, for people living in remote and rural communities. So I think making sure that we continue to invest in these kinds of communities and offer transportation or different activities and alcohol-free spaces, etc. All of those things I think are really important and really relevant. And as we move forward, as I say, in the next months and years, the lessons we draw from this can be that I think there's, as I say, lots of opportunity to continue with some of the things we've learned actually work better in terms of remote working and online services. But we'll need to make sure that we monitor and evaluate these services and make sure that quality and standards are maintained, and ask people about their experiences in getting these kinds of services online. And then also we need to make sure we don't let things like assertive outreach, bringing activities and services to people in their communities, that we don't leave these things behind. Can I have the next slide, please? Great, final slide. So this is just to further kind of plug the event and encourage everyone who's interested in learning more about this project and the conclusions that we drew and our recommendations for Scottish Government for research, policy and practice moving forward. I would really warmly invite all of you to join us online on the 23rd. If anyone has any questions, my email address is there. You're very, very welcome to get in touch. I've also included our Twitter handle and the link for joining the event and registering. And yeah, hopefully that was of interest, and hopefully see you on the 23rd. And thanks again so much to SDF for an opportunity to share some of our initial findings. And yeah, thanks very much.
Thank you, Jacky, for a sneak preview of some of the findings from the research. We've now heard from all our speakers, so it's time for the question and answer session. So I'm hoping that Wendy and McConnachie is also able to join us at this point, and to invite everybody back to the session and Austin to help us through the questions.
Oh.
Hi Fiona, will we just proceed with the questions? I've finally mastered this after doing it many times by creating a Word document of the questions. So as it stands, we have 6 or 7 questions which should take up most of our time, but I'm still willing to take more if anybody in the audience has got a burning question. The first question is specifically to Jacky, but maybe everybody could give an insight into this. Is about Jacky had a graph about IEP provision, about needle exchange services during the early part of lockdown. And is there any assessment or understanding of what happened to OST, what happened to people in treatment at that time? Did people manage to get their treatment? Did people manage to join in treatment or start to initiate treatment? And did some people leave?
Right, well, for the OST, our specialist drug and alcohol service were really quite on the ball with that, and especially with pharmacies as well, who were reducing their hours. They made arrangements for some of the clients. They risk assessed the clients to see who would actually could have, rather than daily dispensing, the likes of weekly dispensing. So there was a lot of really quick work done within the specialist service to actually arrange all that. So we didn't have anything, I think, that stood out to say that there would be any problems with it. I mean, they were offering to do things like delivering to people as well. If people were, were shielding, they would deliver to them as well. All our services all their opening hours were as normal. So if any new referrals could still get access to a service. So again, there was no issues with that either. What else was there, Austin, did you say? You're on mute. Sorry,
it was just about whether people had managed to get their OST, and if people would be able to start or come out of treatment. And sorry to pick on you. I think the question was spurred by your graph about the needle exchange, but if there's any reflection from other areas as well. Well, certainly no for us. I mean, really the kind of, I think the fact that all the services really came together quite quickly. I mean, we all had to do something, so that that is absolutely fantastic, the way that they all work together. But we didn't seem to hear any issues about people not being able to access the services or get their their opiate replacement therapy. They were all, everything was catered for as it was need be. And the second question is a more general question, but I suppose these things are all related, is about, have we a sense of what happens with actual use of alcohol and other substances during lockdown? There's a lot of sort of impressionistic stuff in the media about whole populations, but in terms of people whose use is maybe problematic. Rhona? Can I just jump in again? I wish I had it to hand at the minute, but my colleague Barbara Zaman, who a lot of you will know, has just finished doing a bit of feedback on the COVID with the service users. So we've got a kind of draft report that's that we need to have a wee look at. But I think from what I can remember that there was change in people's usage, but off the top of my head, if you were to ask me to what they were, I couldn't tell you, but there was definitely some who declined and some who increased. Yeah.
Austin, I'm wondering if Wendy would like to add anything in at this point.
Maybe Wendy didn't hear the question. I think now what we're seeing is an increase in people looking for opiate replacement therapy. So we're seeing an increase in numbers in our service now. So that probably reflects an increase in drug use around the island for us, or an increase in availability. I think in terms of alcohol use, I don't know that we've really seen anybody who we wouldn't have seen before. I think that might well come out later on. I think lots of people have struggled to deal with COVID, and I think what patient groups struggled, but I think as a population in general, we've struggled. I think we certainly are seeing quite a lot of chaotic behaviour just now. But again, it's difficult to really link that to an increase in drug or alcohol use. It might have been there anyway without COVID. So yeah, I'm not sure yet, I suppose, from our end. But it seems to be an increase just now, but we can't quantify that.
Excuse me. The third question was about naloxone. Was just a clarification that everybody's still providing the same naloxone product that they have been traditionally. And what happened with supply? Was there more demand for supply, and did we manage to make a supply or innovate ways of making a supply?
Well, I start with that one, Austin, from Borders experience. Well, we, in the kind of run up to lockdown, and when we thought that things were going to change significantly, the services actively sought out people they thought to double check that their naloxone was available and ready for use. Unlike the other areas, we still maintained the ability for people to drop in and or see face to face. So we did have a bigger supply than usual in the first quarter of this year and this fiscal year, and some new people to service more as well that we hadn't managed to reach before. So that felt reassuring. I'm not sure if Jacky has something to add.
Yeah, one of the things that our specialist service did was everybody who was on OST, whether they had already previously been supplied or not, when they were going in, they were actually given another supply of naloxone to make sure that they were covered. But naloxone was offered to everybody else as normal over the period of time, but that was the only thing that was probably more specific, was around clients who were on OST, to make sure that absolutely everybody had a kit.
Thank you. And yeah, the other thing is just about providing support online or by telephone rather than meeting people face to face. So there was two kind of points around that. One of them was that while some people give you very positive feedback around that and enjoy it and maybe think it's better than doing face to face, what are the issues in a rural area with people who don't like that? I think the implication is that some people prefer not doing face to face and doing something online because they don't have to do the public transport thing of getting to the service. But for people who actively dislike that or do not prefer that mode and would rather speak to people face to face, how do we monitor that if those people just become very quiet or they withdraw altogether?
Yeah, that was something that certainly came up during our conversations, because I think there, as you say, quite a stark difference in people's preferences. And also something that I didn't really mention, but is certainly relevant, is also access to like good internet and broadband is an issue as well for some people. So even though you might think, oh, online services are very equitable, that's actually not necessarily the case for everyone as well. So yeah, I think in terms of just the monitoring and evaluation piece of online services, I'm certainly following up with people who drop off and asking, was this the reason? And then, as I think in hearing the other presentations, it sounds like there's still a focus on doing in-person, consultations and counseling, etc. So I think that's good, and let's not entirely move away from that, and let's certainly hear feedback from people with lived experience and service users in asking them what their preferences would be. I'll let the others chime in with their thoughts on that.
Rhona and Wendy, do you have anything from your perspective?
Yeah, just as Rhona described, the service locally has been really good at continuing to provide the face-to-face support and being able to communicate with people in the way that's most suitable for the individual. I think, just as was mentioned previously, issues around good broadband coverage, good mobile reception, things like that, in somewhere as remote as Shetland is challenging for people, and also access to equipment. I think it's sometimes assumed that people have access to the correct equipment and money in their phones and things, for example, but that's not always the case. So I think that what Rhona described was a really good mix of being able to respond to the individuals in the way that was most suitable for them.
Jacky, did you have anything additional to bring in there?
Yeah, probably the only additional thing I would say, that one of the things that we did do was to make sure that anybody who didn't have a mobile phone, we purchased a phone for them and we purchased credit for them, so that they could actually get telephone conversations with one-to-one service. So that was probably the only other additional thing I would say in regards to everybody else's.
Thanks, Annette. One of our services had a different reflection slightly, which is related to this, in terms of people being unable to come in because they were, for example, shielding, and so people were having a home visit, but noted how valuable those home visits were as really getting to know the person in their own environment, and thinking that going forward that's likely to be a change in how services is delivered to incorporate more of that, seeing people where they're at rather than purely either remotely or in a clinic or other venue.
Yeah, the other question on that topic is about initiating people in treatment or engaging with a new service. When that's done online initially, or some of it's done online, it's just a question about how you build that therapeutic relationship, how you actually have a relationship with somebody that you've never actually physically met, or you've maybe physically met once for initial assessment or something.
That's maybe one for Rhona. She's the person in the delivering a service directly.
Yeah, I guess we didn't. Those were the people we saw face to face, and I suppose because of the community that we live in and we serve, quite often we'll know the people who are coming back into treatment. We'll have seen them before. But yeah, no, I mean, it was really important to, as safely as possible for patients and staff to see people and build that relationship. And then sometimes if it's not been possible to have face-to-face appointments, telephone appointments, but I mean, as Wendy said there, that's easier said than done sometimes. So we still saw people, and people were happy to wear masks, and people understood the boundaries, and yeah, people were happy for contact. So it worked for us.
Thank you. And the next question is a kind of a wider question, and I can almost feel the pain in it. And the question is that and actually I'm ashamed to tell you I didn't know this, if this is accurate, but the words remote and rural don't appear in the strategy document, Rights, Respect and Recovery. And what I can almost certainly say is that they'll certainly be underrepresented if they appear at all. And what are the consequences of that? Do people working in remote and rural Scotland feel excluded or unsupported by the centre? And what are the consequences of that, particularly for people obviously who use services or could be using services?
I wonder if any of that came up in Jacky McDermott's research, the SHAP research.
Yeah, I was just nodding vigorously at that, because I was also so shocked to see that actually the words remote and rural don't appear in either the alcohol framework or Rights, Respect and Recovery, which I think, yeah, that certainly is going to inform our recommendations to Scottish Government in terms of having some very specific work streams and staff dedicated to making sure that the unique experiences of people in these areas are catered to. And acknowledged and mentioned, because I think that's like a very important first step in order to assessing needs and offering support. So yeah, I think I'll let the others speak to about feeling excluded or anything. But yeah, on one other, I guess, topic, as I mentioned in my presentation, I do think that's one positive, is that if we can have more kind of online training and meetings such as this. And I was speaking to people saying that the ADP meetings being held online, it's actually much easier, because if you have half of everyone in a room, but the other half teleconferencing and or video conferencing, it's just natural that the others kind of get left out, and it's awkward and you can't hear everyone, and it's just hard to jump in. Whereas if you have everyone together in an equally kind of, seated at the table online, if you will, I think that's just much easier. So yeah, those are my initial thoughts on that.
Thank you. Somebody else, anything else on that?
Yeah, I'm going to mention the F word, as in funding. Yeah, I think sometimes centrally, whilst we might have smaller populations, and the funding kind of reflects the numbers of people and the rate, I think sometimes they forget that, there's a lot of other things, that the rural issues and about where you deliver services and how you get services to people. So if you're providing the likes of mobile outreach or anything like that, these are further costs and the further places to drive. If you look at Dumfries and Galloway, and it takes me, the same time to get to Stranraer as what it would be to get to Glasgow. So it's quite a wide area that we're actually covering. So if you're trying to deliver services or get people to actually access your services, they need to kind of think about the wider aspects and not just base kind of like the funding issues on numbers of people.
Yeah, I think there is something about that, just the logistics in a local area. So we may have a per head of population a similar size team, but they're spread more widely, and just because we're a small population. So in Borders there's 114,000 folks. So pro rata we have maybe we've only got maybe 10 or 11 people to run a whole service. So trying logistically to spread that. And I think with the quite rightly the expectation of 24 hours, 7 days a week service, how you manage that for a relatively small population is quite challenging. And I think we're all good at partnership and cross-cutting work, but it still is challenging to do that with just a small team of people to run a service. And so some of the solutions which are very obvious, I think, and would be really helpful, are just possibly a bit harder to translate down to a more rural area.
Yeah, I would agree with all the points that have been made as well. I would just like to add, in terms of national support for the ADP, a positive that's come out of COVID is that we have never felt so connected in the island group of ADPs. It's been a long-standing kind of problem that island ADPs have wanted to be involved in national activities, and it's just not been possible. We don't have the budget afforded to us to travel to the mainland to attend even the quarterly national meetings. So actually the fact that everyone during COVID became unconnected has actually been a real positive for the island ADPs.
No, thanks, that's useful. I mean, talking from an SDF point of view, that's absolutely true. Well, we've prided ourselves in how much we've travelled to Shetland, Orkney and the Western Isles and remote mainland Scotland. The webinar attendance is phenomenal from people in remote and rural Scotland, and I would hope we would never go back to a situation where it'd been so centralised. It's transformative. So no, thanks for that. The last question, if we have time for it, just the question that we've traditionally asked is that we've had a lot of changes forced on us by the pandemic, but what is it you would love to keep?
I think in terms of our service, I think our ability to get out in the community we serve and see people where they are, rather than, and it's being touched on there, rather than everybody having to come in for us, it's the town, the central point. I think what I'd like to see is that we are not so office based. We go out and we see people where they are, and because I think for me, part of all our work is about reducing the stigma and helping people to recover in their communities, and I think if we can move out and be more locality based, will help do that. So
Jacky, or
Oh, sure. I'm gonna jump in and just say from speaking to people, I think speaking to people who are active in their recovery communities, I was so impressed and really inspired by the creative solutions people have come up with getting together, in terms of, like, instead of people customarily having a recovery cafe where people share a meal and that kind of thing, and they've had to, obviously with not being able to gather in an indoor space, they've had to get creative and think of other things to do. And so yeah, these like gardening and walks and the recovery rambles and that kind of thing, meeting outdoors, I think that's amazing. And I imagine that will be much more challenging during the winter months, but I do hope that kind of those kind of initiatives can continue, and that I think it just, yeah, it adds another opportunity for people to get involved in that kind of thing. So yeah, I would keep that if possible.
Thank you. Is there anything else, Jacky or Fiona?
I think really what people have said before about that willingness to work and think a bit differently, and including events like this where we can be better connected. And I think that enthusiasm from the services that people are reporting just to do the right thing, and even though it's something different, has been just remarkable.
Thanks.
Yeah, probably just from me is actually seeing the service users adapt, how quickly they were actually adapting to the change as well, because we always presume that they're not going to like change, and so I think we were quite surprised, especially with the outreach IEP clients, how quickly they actually adapted to new staff, people they weren't used to. So that's a really positive thing, and that's the one thing that I think out of all this that we will take forward is we know that they will change if required. So and it will be based on their needs as well, I suppose. So yeah.
Yeah, and I think part of the key driver for that is that people accept change, that they understand the motivation for that change of what's driven it. So I think that's been key as well. And thanks for that. I'll just hand back to Fiona then, if you want to finish us off.
Thanks, Austin. Thanks, everyone. So unfortunately, that's us come to the end of this webinar, but it has been recorded and it will be available on the SDF YouTube channel in the near future. And we will also be able to see the previous webinars there. An evaluation link will be sent out, so please do fill that in if you can. The next upcoming webinars, Scottish Drugs Forum is working with the Scottish Drug Deaths Task Force to host 2 webinars on the use of illicit benzodiazepines in Scotland, and where they're going to cover the link between benzodiazepine use and fatal overdoses, and also the means to challenge the impact of benzodiazepines in Scotland. So the first of those seminars is on the 2nd of October, and the second is on the 9th of October, and the links to join them will be in the evaluation questionnaire that you will receive. So thank you for everyone for attending today's webinar, and especially thanks to our speakers and Austin for their contribution to what's been a really interesting and informative session. So thank you again, and goodbye from all of us.
Thanks, bye.